Order, please. I'd like to call the meeting of the Public Accounts Committee to order. First, if I could remind everybody to put their phones on vibrate or silent. And we'll ask the committee members to introduce themselves, beginning with Ms. LeBlanc.
Good morning, Susan LeBlanc, MLA for Dartmouth North.
Good morning, Lisa Roberts, MLA for Halifax Needham.
Good morning and welcome. My name is Barbara Adams. I'm the MLA for Cole Harbour Eastern Passage.
Good morning, Rafa Di Costanzo, MLA Clayton Park West.
Hi, MLA Suzanne Lonis-Croft, Lunenburg.
Good morning, ladies and gentlemen. I'm Ben Jessam, and I represent Hammonds Plains Lucasville.
Good morning, Leo Glavine, MLA Kings West.
Hugh McKay, MLA for Chester St. Margaret's.
On today's agenda, we have the witnesses with us to discuss Chapter 1 of the December 2018 report of the Auditor General regarding management and oversight of health sector information technology. If I could, I'll ask the witnesses to introduce themselves, beginning with Ms. Grimm.
Good morning, Christine Grimm, Senior Executive Director for Digital Health, Analytics and Privacy Office and Health.
Good morning, Denise Perret, Deputy Minister, Health and Wellness.
Good morning, Jeff Conrad. I'm the Deputy Minister at Internal Services.
Good morning, I'm Sandra Cascadden, Chief Information Officer for the Province of Nova Scotia.
Good morning, I'm Janet Knox, President and CEO, Nova Scotia Health Authority.
Good morning, I'm Allan Horsburgh. I'm Vice President and Chief Financial Officer of the Nova Scotia Health Authority.
Hello, I'm Krista Jangard, the President and CEO of the IWK Health Centre.
Good morning, I'm Tim Guest, Vice President, Health Services and Chief Nurse Executive with the Nova Scotia Health Authority.
Good morning, I'm Chris Mitchell, the Chief Procurement Officer for the Province of Nova Scotia.
Thank you very much. And if I could now ask the witnesses to have a brief opening statement, please. Ms. Perret.
Thank you for the opportunity to discuss the work we're doing in modernizing Nova Scotia's information management and information technology environment, which we refer to as IMIT. The Auditor General has provided a report on IMIT that raises important questions and has provided us with some solid recommendations. All our 4 organizations agree with the recommendations made by the Auditor, and we're working together to respond to them. I think, and you'll see from the discussion we have today, I think it's helpful to put this in the context of some of the province's major restructuring initiatives. And from 2014 to 2016, you have 3 initiatives that stand out. You've got the consolidation of the regional health authorities, you have the restructuring of the Department of Health and Wellness, and you have the passing of the Shared Services Act, which consolidated Health IMIT on an infrastructure basis in the Department of Internal Services and on a clinical services basis in the Nova Scotia Health Authority. These are really important shifts in the system. Typically, departments and public agencies operate within their organizational boundaries, and they often operate in a hierarchical structure. But we're increasingly seeing how technology disrupts these forms of systems. We've seen it in retail and transportation, from Amazon to Uber, and it's forcing us to work differently. So the old forms of organizational silos are no longer an option in a modern system. So as we change the way we work, it's valuable to have feedback, as we received from the audit that we're discussing today, to make the kind of course corrections that move us forward towards strengthened relationships and better results for patients and providers. We are fortunate that we have 2 ministers of our departments and 2 chairs of the health authorities who are focused on IT issues and who bring a tremendous amount of expertise and experience to the table. And I can tell you that they have ongoing discussions in their formal and informal meetings on this topic. Their input and direction, along with the audit, led to the development of the organizational chart, which we handed out and which we may refer to during the discussion this morning. It sets out the governance structure that we're currently operating under and which will continue to evolve. Some parts of this structure have been in place for some time, while others have been informed by and responding to the audit. In brief, we've brought existing streams of activity together into a more comprehensive governance structure. And this type of move forward is one of the reasons we appreciate the auditor's report and have already benefited by the recommendations. So in short, I appreciate the opportunity to be here to address your questions, and we look forward to the discussion.
Mr. Conrad.
Well, good morning, and thank you for having us. As you've heard just a few minutes ago, I'm joined this morning by Sandra Cascadden, the ADM of Internal Services and CIO for the province, and by Chris Mitchel, the Chief Procurement Officer for the province. I just want to remind you that the Department of Internal Services was formed about 5 years ago to perform many of the corporate functions of government and a number of our partners. We provide a wide range of services, including financial transactions, procurement, insurance, business continuity management, a host of IT services, and we even house the Internal Audit Centre for the Government of Nova Scotia. When government made the decision to create the department and then to undertake a shared services initiative, it was an intentional effort to do a number of several related things. One was to allow our service delivery partners to focus on those things which are most important in delivering services that Nova Scotians depend on. I think most of us would agree that what we want my colleagues from the 2 health authorities to spend their time and effort working on are critical health issues. Not on how many people are working on the IT service desk today, or whether they have a contract in place to buy new laptops, or even if the computers are going to work in pharmacy and ER today. Those things should be something they can take as a given and be just one more tool they depend on to ensure patient health and safety. One of the other outcomes from shared services was for internal services to become an organization with a strong quality service perspective and an economy of scale and technical expertise that provides support our partners can depend on. This has been a transformative process, as Denise talked about, with internal services gradually taking on more responsibility over the past 5 years and providing a wider range of services. I appreciate the report from the Auditor General, as it helped remind us of the importance of ensuring we have good, clear governance practice amongst these trusted partners. As you'll hear this morning, we have shared many success stories amongst these partners across a range of fronts. For example, more than $150 million in projected procurement savings based on work done over the last 4 years across government and health authorities. Great successes such as a new health storage area network that provides not only more secure storage for programs, but at a reduced cost of over $90,000 per year just in the calculation of utilities usage. A new experience when you enter the Dartmouth General Hospital reception area and take advantage of patient self-service kiosks and digital signage. And leveraging joint buying power by cooperating on how we buy and set up desktop and laptop computers. These are just a few examples. Internal Services is on a journey of continuous improvement, and reports such as the one from the Office of the Auditor General directly inform our processes. Our ability to adapt and improve our work in a highly dynamic environment has been acknowledged by the receipt of 2 IPAC Innovation Awards, an Excellence Canada certification, a National Procurement Award, and an independent audit practice confirmation. We've been asked to share our expertise in shared services at a variety of professional conferences and forums, both nationally and internationally. So I look forward to the discussion this morning. Thank you.
Ms. Knox.
Good morning. Thank you for the opportunity to be here this morning. I'm joined, as you've heard, by my colleagues, Tim Guest, who's our Vice President of Chief Nursing Executive, and Allan, Horsburgh, who's our Vice President of Corporate Services and Chief Financial Officer. Better health data can lead to better patient outcomes, better patient care, and better system performance. Information technology is a very important tool for our healthcare providers. It helps them have the information they need to provide care to Nova Scotians and the information we need to manage the health system effectively and efficiently. It is critical to the delivery of safe, high quality, and service delivery. The present health IT landscape in Nova Scotia is a patchwork of applications and databases that have been implemented over many years by the separate organizations that preceded Nova Scotia Health Authority. Within Nova Scotia Health Authority alone, there are hundreds of clinical information systems supporting the delivery of direct patient care. They help patients be registered to our hospitals and clinics, get lab and diagnostic imaging results, and ensure they get the right medication. But many of these existing systems are old and costly to maintain, and equally importantly, lack the functionality that our clinicians need and want. They don't talk to each other, which means it's not always easy to access and share information needed for patient care for the planning and monitoring of our system. So our goal as a system is a single integrated health record for every Nova Scotian. While that's still some time away, we are taking steps to modernize and integrate our existing health information systems, and we are working very closely with our partners in government to strengthen our management and oversight of these crucial systems. For example, Nova Scotia Health Authority and the IWK have signed a service agreement to formalize the service relationship between our two organizations. And we've been working to clarify roles and responsibilities and ensure that there are clear owners for each piece of information technology now and into the future. Our teams have done a lot of great work to better support frontline users. For example, there is now a major incident process for system downtime. Risk management is an ongoing concern for the health sector, and we have a number of controls in place to identify and mitigate risks. An example, we have access and privacy controls to limit access to clinical information systems based on an individual's scope of work. We also have auditing software so we can monitor who goes into that system and what they access while they are in there. It may be surprising for you to know that I have no access to patient information. I don't need that to do the work that I do. There is constantly evolving issues, so we work closely with government to ensure we are responding appropriately to protect our data through technology, such as antivirus software, firewalls, and operating systems updates. And as reference, we are working with our government partners to adopt COBIT 5, which is the industry best practice for IT governance and risk management. In the meantime, we continue to identify, evaluate, prioritize, and manage our information technology risks through our enterprise risk management system at Nova Scotia Health Authority. By modernizing and simplifying our information technology environment as we move to a more integrated health information system, we will help ensure that patient information is readily available to healthcare providers when and where it is needed. This will support the delivery of patient care and allow us to better plan, monitor, and improve system performance. Thank you.
Ms. Jangard.
And thank you. Excuse me. I'd like to echo Janet's remarks and tell the committee that the work we're doing together collaboratively, strengthening and modernizing our IT systems to better support our clinicians and healthcare workers to serve the patients and families we do is something we value greatly. As the IWK works with our partners that are seated with me here today, we reap the benefits of seeing the system as a whole, tackling our common issues together, and planning the future with a shared vision. That vision will not only improve access and efficiency, but will provide patients and families with what they want and need, a seamless system that sees them holistically throughout their healthcare journey, no matter where they are. After over 25 years as a frontline physician, I understand the complexities of healthcare and the systems that support it. I also understand that there are no easy solutions sometimes when we have a complex patient, and we must take the time to analyze, diagnose, and develop a treatment approach that will ensure long-term health. The same can be said when we are approaching decisions for our health IT systems. Speed should not be the crux of how we approach things. We know that the best solutions often cannot be rushed, but if done properly, will stand the test of time. That is what Nova Scotians expect and deserve. So we look forward to being here with you today and answering your questions. Thank you.
Thank you very much, everybody. Now we'll open up the floor to questions, beginning with the PC Caucus and Ms. Adams.
Thank you, Mr. Chair, and thank all of the guests for being here today. Last week at the Health Committee, we had an opportunity to speak about the accreditation report for the Nova Scotia Health Authority, so we're back on familiar territory. I do have a question, and I'll leave it up to you to decide who's going to answer the questions. The amalgamation of all the district health authorities happened several years ago, and as Mr. Conrad said, the Department of IT has been functioning for the past 5 years. So I'm wondering at what point we stop referring to the fact that we were in a point of transition. These things happened at least 4 years ago. So when we look at the Auditor General's report, you know, how much of the issues that he identified are we maintaining were created because we were amalgamating 9 districts versus just we weren't following the recommendations instinctively? So the question is, for the past 4 years that the amalgamation has been over, technically, how much of the issues that the Auditor General raised are because of amalgamation and therefore are done and over with, and we don't have to keep referencing back to the fact that we were in a process of amalgamating?
Ms. Perret.
So it's a good question, and it's a complicated question. So I think in part, it's important to keep in mind that what the auditor focused on, and I'll refer you to the org chart, is the left side of the chart, and some of the amalgamation that took place in the operation of the system with IMIT. On the right side of the chart is what I would call the strategic health digital initiatives, which are key policy initiatives, like One Person, One Record, or what we call OPOR, My Health Nova Scotia, Panorama, which is a public health platform, and the drug information system. So in part where my answer is going is that it's a very dynamic system. Technology in the healthcare space is evolving rapidly, and it offers tremendous opportunity. It's also a very complex dynamic. So in part, this is an evolution. It's a transition that doesn't stop at any one point. And our focus, certainly from the department, if you look at it as a right side of the chart policy, left side of the chart operational, is a policy operational divide. There may be members here who want to comment further, but I think on the operational side, the left-hand side, which is the focus of the audit, I think that the IMIT Steering Committee, which is a group of very senior officials in government, many of whom are here, they would say that they are at cruising altitude. That many, you've seen it in the report we tabled on the action plan, that a lot of that was close to completion. But this is going to be a process of continuous improvement.
Okay.
Ms. Adams.
Thank you for that answer. Were any of the recommendations that the Auditor General made a surprise to any of you? Or were you aware of the problems all along?
Mr. Conrad.
I think what we would say in terms of the recommendations of the Auditor General is that many of those recommendations were in fact in progress. So when you see a recommendation, for example, to complete the reports, complete the agreements that we have amongst ourselves, those agreements were in draft form and did exist. So we were working towards completion of those. So again, we appreciate the recommendation of the Auditor General that perhaps they should have had a little more attention a little earlier in the process. But I think as some of the comments that have already been made, the importance of building these relationships, really understanding each other's work and environment, getting to a stable point in terms of the ability to work together, maybe was operationally, we had a little more focus on that side and didn't spend the kind of time that would have been desired to finalize those reports. But were we surprised that the auditor would look and see that we had relationship management documents in progress and suggest that we should finish those as we were on track to do? That wouldn't have been a surprise to us. That was certainly work that we had already started.
Okay, thank you. On page 9 of the report, for those who don't have the luxury of having read the Auditor General report, one of the first comments is that the Department of Health and Wellness is not effectively leading IT in the health sector, and it says the Department of Health and Wellness has not provided the level of leadership and direction required to effectively transition the health sector to centralized information technology services. So I'm, again, leave this open to who wants to answer it. What's the explanation for the lack of leadership and direction? Because that's not a document that was about to be finished. So what's the explanation for the lack of leadership and direction from the Department of Health and Wellness in effectively transitioning the health sector to the centralized information technology services? And what are you planning on doing to address and remedy the information that was missing in terms of the oversight?
Ms. Perret.
Thank you. So again, please have reference to the organization chart, because the audit is commenting on the operational side of the equation. And I think it's fair comment that in health and wellness, when we went into a shared services environment, many of our digital health resources went over to the Department of Internal Services, and we did pay less attention on the operational side. So the agreements that are in play being finalized, largely driven by internal services and the health authority, are under the purview of the steering committee where Ms. Grimm sits on and some of our staff. But our focus has been primarily on the strategic digital technology side, which is the right-hand side of the chart. So where the audit didn't comment, and I think we have to be careful not to take the comments in the audits to an overly broad point, is that the Health IMT Governance Committee that you'll see on your chart and the right-hand side of the chart has been in effect for several years and has been meeting. And what we have done in response to the auditor's report, because what the direction is to the Health Committee, and the comment is made on page 10, at 1.6, is the auditor says that the recommendations throughout this chapter are directed at the entities responsible to act, but health has to provide leadership. So what we have appreciated from this report is that we needed to join the operational side and the policy side under the one governance structure, and that's what we've done. Okay. In short, I don't want you to have the impression that there was no governance structure or governance activities. We were focused on strategic priorities. We have the operational side focused on operations, and we've brought those two together.
Yeah. Okay. One of the first recommendation is about having the signed agreement related to the information technology, including the roles and accountability for each entity between the Department of Health and Wellness and Internal Services. And somebody referenced, I think at the beginning, that there was now a signed agreement, and I'm just wondering when that was signed.
Mr. Conrad.
So the audit calls for a number of agreements to be signed, and a number of those are amongst the 4 partners, and some of those are amongst subsets of those partners. So the agreement that was signed in November of 2018 was the agreement on the transfer of resources and responsibilities between internal services and the other agencies. So that agreement is now completed and signed, and it details which staff came to us, what kinds of duties they have, what kinds of duties we provide back, and some detail around how we do that work. Still outstanding are 2 more agreements, which we intend to have signed by the end of March, that are across all 4 partners, and one of those is an agreement which is very specific on the IT duties and responsibilities. So it details quite a detailed level, and if you'd like to know more about that, we can have Ms. Cascadden speak to that, but in a fair level of detail around the kinds of services and activities that we provide to the partners. And then the other agreement that is yet to be signed is what we call the master agreement. So the master agreement is the one that would sign off on things such as the audit has suggested around what kinds of committees are existing in place, how we work together, how we resolve disputes, should there be disputes in the process, those kinds of things. And it will also be signed before the end of March. There are 2 agreements between the health authorities that do not involve internal services, and I believe at least one, if not both of those, are now signed as well.
Okay, thank you. Given that you said the master agreement is going to outline how you work together and resolve differences, why is it not already signed? What's been the delay? And that's a fairly significant document to figure out how you work together and how you've resolved disagreements. So what's been the delay in getting that signed?
Mr. Conrad.
So agreed, it is an important document. The reality of how we work together is that, these were existing people that were transferred into the Department of Internal Services' existing responsibilities, and we had professional agreements amongst ourselves to work in much the same way it was pre-transition. So we talk a lot in these big transformational projects about transition, stabilize, and then transform processes. So it's not that the processes and committees that are in place in the governance document and the master agreement have not been in place per the org chart that we've referenced here. Those committees existed, they were meeting, there were good working groups, there's wonderful work being done amongst the partners. The master agreement codifies those things and puts in place the written relationships. For the most part, we've resolved a lot of the issues, or most of the issues, around the IT parts of the agreement. What's holding up the agreement conversations are the more technical things around, for example, sharing of HR information, liability responsibility with outside insurance companies, things like that, where we have lawyers working through making sure that we have the right language that respects collective agreements, partnerships with external vendors, things like that. So we've got the majority of the work done, and we're working on the final technicalities to get those done by the end of March.
Okay. Thank you. One of the other comments from the Auditor General's report on page 10 was the health sector has not formally agreed upon the roles and accountabilities, including clinical applications. So I'm just wondering how close you are to having those roles and accountabilities spelled out.
Ms. Grimm.
Thank you for the question. Certainly prior to and since the transition to shared services, we went through a high-level roles and responsibilities exercise as part of that transition. At that point, that's very much an academic exercise. It's not until you start living and actually doing the work that you realize there may be some areas where there isn't a full alignment. As a steering committee, we actually identified ourselves the need to complete a roles and responsibilities exercise. We call it a RACI. It's roles, responsibility, accountability, who else has to be consulted and who has to be informed. That type of an exercise allows you to drill down to the level of work to make sure that there is clarity about who does what. And so we had a few areas where we knew that perhaps there was duplication and a lack of clarity, and we took that on upon ourselves. The Auditor General referenced that in the audit, but it had been underway for some time prior to the audit. During the audit, we were also in the midst of a big procurement process. So most of the people involved with that procurement process and those work streams, we actually put the RACI on hold for a bit and came back to it after that period of time was completed. We've since completed the workshops in December and January, and we intend to have a report that will go to steering and then to governance before the March 31st date.
Okay. Perhaps somebody could clarify for us right now, Ms. Knox, you mentioned that you don't have any access to patient records. Who does have access? And is there a different level of access depending on your health profession?
Ms. Knox.
Thank you very much. A very important question. Privacy of health information is #1 for all of us as individuals. And so as a healthcare organization providing care, it's very important. So we have job descriptions that define what people's roles are, and access to information depends on your scope of work. And so when I reference myself, my job is not to plan individual patient care or to have any input into that. My job is to make sure that there's an organization with the resources and the right expertise to provide the care. So when we hire people, they are educated in terms of what their access is, what our rules are around privacy. They sign a confidentiality agreement. We have ongoing education. And so it's very clear for people what their roles will be. So if you're an individual who is a clerk making appointments, you have a specific access. If you're a nurse or a physician or an occupational therapist or providing care, you have access to the patients for whom you provide care. So it's very prescribed. Right. And it's a long-standing process in the health system, and one that we hold very important to the work that we do.
Thank you. I wonder if you could tell me how many times somebody who wasn't supposed to access patient records has done so, and how do you track that?
So we have an auditing process, and I think it's 5 times in 2018 that an individual went into we call it snooping, looking at other people's information 5 times in 2018.
And was that one person looking at 5 different people, or was that 5 different people?
5 different people.
And what happened to those people?
So we have our process, we have a progressive discipline process, and so it depends on what the level of activity was and intention. There's a whole process.
Okay.
So which can include termination.
Right. I mean, in 5 people in all that time, that's a very good...
Well, we have, as you know, 24,000 employees, almost 3,000 physicians, 500 learners, and 7,000 volunteers. Yes.
That's great. Thank you. When we move to the one patient, one record, who is going to have access to that? So if I'm in private practice and I want to look at somebody's x-ray, am I going to have the ability to do that? And is a patient going to have the ability to share their record with whoever they want?
Ms. Grimm.
There is a work stream assigned to one person, one record, looking at that responsibility of a fully integrated record so that each citizen has their own record. That being said, certainly the FIA Personal Health Information Act applies to and does not change as we transition to a lot of the processes that Ms. Knox talked about as far as user access and those types of things will continue within the healthcare system. People should have access to information within that circle of care that they currently work within. So those types of things don't change. What we do need to do with this work stream is actually look at specific opportunities around an integrated health record and make sure that we do have compliance with FIA as we move forward. So, for example, there is some integration with EMRs. Physicians are custodians of that data, whereas the hospital information systems are under the custodianship of the health authority. And so there are some process pieces to be worked through to make sure that there is the appropriate oversight as per FIA. So it doesn't really change. It just needs to be planned for and managed.
Okay, so if you're running a home care company, is there a possibility then that you would be able to access those records?
So it's important to understand the scope of OPOR at this point in time. At this phase, we are actively in a procurement process for a clinical information system that replaces the 3 hospital information systems.
Okay.
And so future phases will look at that and we'll have to address that, but for this procurement, it is focused on that.
Okay, great. Thank you.
Thank you.
Since the introduction of the Shared Services Act, I know that everybody's trying to work hard to cooperate amongst the 4 groups that are represented today. So in order to meet the needs of the IT health sector, could the representatives here explain to us any internal issues that you're facing that are a hindrance to the pursuit of the cooperation, as well as explain how you plan on solving them, because you mentioned some difficulties that may have been there in the past in terms of working together. So I'm just wondering if each of you could explain to us what are some of the challenges that you're still trying to overcome moving forward in terms of cooperating together.
Mr. Conrad.
So maybe I'll let Sandra speak in a little more detail. You know, I think one of the things I would say just in terms of structure and process here is that, you know, these are very complex systems that we work in. It's a very complex environment and a very quickly changing environment. So, you know, the relationships amongst all the partners are really strong. The things I see in terms of sort of future challenges for us are more related to the environment in which we work in terms of changing technology and things like that. But I'll let Sandra speak in maybe to some detail around a few things that are coming up in terms of the way the world works on IT.
Ms. Cascadden.
Great. Thank you very much. Some of the challenges that we experience on the health side are challenges that are similar that we would experience in IT in general. One of the major challenges is that the demand is outstripping the supply. So the demand for changes associated with moving into the digital world, the numbers of systems, the technology, the rate of change in the entire industry, those are kind of the key things that really impact how we work together and the speed at which we need to work. The relationships that we have are strong relationships, and we've had them for a number of years. The teams work at multiple different levels in the organization. They work at the operations level, they work at the management level, they work at senior levels for a strategy perspective, with the support of the higher levels of the ministers and the deputy ministers. So we have a really good structure to support the things that we're doing.
Order, please. That ends the time for the PC Caucus. I'm going to move to the NDP Caucus and Ms. LeBlanc.
Thank you, Mr. Chair. I'd be happy if you wanted to finish your response there. I mean, if you have more to say, go ahead.
Thank you. There are other, there are other challenges that don't directly relate to the health sector, but again to IT in general. The major challenges from a technology perspective in today's world, of course, are cybersecurity, privacy, and going to the cloud and cloud-based technology. So those are challenges that we are dealing with from an operational perspective, and I'm confident that the partnerships that we have and the relationships that we have, we will be able to tackle those.
Ms. LeBlanc.
Thank you again. I have a question for Ms. Perret. I just wanted to, we talk a lot about IT systems and all of this sort of high level technology discussion, which frankly I find interesting, but somewhat inaccessible. But I want to bring it down to a patient level. And so I'm wondering if you could sort of talk us through an average Nova Scotian's patient experience with IT systems in healthcare. So, what would it look like if someone presents at their family physician or at the emergency room, for instance, and how, like, their journey through that, how does information technology affect them?
Ms. Perret.
I'll refer it to Ms. Grimm, please. Ms.
Grimm, please.
So I'm going to keep this at a very high level because there's many systems involved, as Ms. Knox had talked about in her opening remarks. We've kind of bucketed those systems into those clinical systems used by providers, the system that's used for public health and public health surveillance, and the system, My Health NS, which is used to provide citizens with access to their information. And it's really those three groupings of systems together that provide the foundation and the modernization of what we're looking for. So within that provider environment, we have many, many systems where patients will enter into the healthcare journey and information will be documented at the point of care when they come in. That information often is shared if it's a lab DI, a test result, or a specialist report into what we call the electronic health record, which is SHARE. The electronic health record actually makes up for some of the challenges we have with the multiple systems we have right now. So because we don't have all these systems talking to each other the way we would like, providers who have user access to the system and have been approved to have that access can actually log on to the SHARE portal and actually see that information in context as it's coming through in the patient journey. And so from the provider perspective, they actually have access to the information there, most of the information they have. Obviously, one person, one record is meant to modernize that foundation and make it a bit more seamless and integrated and to have more information available at the point of care. On the citizen side, if a citizen's physician has currently enrolled in My Health NS and the physician is releasing results, the patient can have access to their information. That was based on the strategy and the pilot that we did from, I believe it was 2013 to 2015. We have since realized that we need to look at that strategy again. We have very busy primary healthcare physicians who have a lot on their plate right now, and perhaps there's a more streamlined way to get information to citizens, and we're currently looking at options to be able to do that, because we want every citizen to have access to their information and to have it when they want it, where they want it, and have it in a digital format.
Thanks. Just to clarify your first part of your answer, so if I go to the emergency room and get assigned tests and blah, 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 and then I get admitted to the hospital, in terms of the electronic patient record, many care providers would be contributing to that record, but are there other systems, like for instance the triage system, is that different than the electronic patient record? I'm just trying to get a sense of how many systems one would be affected by, or where one's information is going, you know, out into.
So from a clinical perspective, I might refer that to Tim, but from a systems perspective, there are hundreds of systems. Okay. And as Ms. Knox had said, we did procure these by functional needs. So there's a cardiology, there's a nephrology. Within the hospital context, there are 3 core hospital information systems, but I think it would be appropriate for Tim Guest to talk about more of the clinical workflow.
Sure, actually I think it's fine. I think that was kind of the answer I was looking for, if that's okay. I'll just move on. The Auditor General mentioned scheduling and registration systems, lab systems, patient record systems as a couple of examples of these that don't have adequate risk management. So I'm wondering if either Ms. Perret or you could speak to the kinds of risks associated with the IT in those systems. So again, picturing, you know, the patient who has just been admitted to the hospital, what kind of consequences are we talking about for that person and bringing it to a personal level, a citizen level, if those systems somehow aren't working correctly?
Ms. Grimm.
So again, I'm going to keep it high level. I believe what the auditor said was that it's not that we don't have risks, it's that we didn't have a risk register. From our perspective, we actually do manage a lot of risks, albeit in a bit more siloed approach across the healthcare system in projects and programs. Certainly from the Department of Health and Wellness perspective, we are more on the strategic arm with the One Person, One Record initiative. There is a full risk register associated with that. We have had risks since we started the initiative back in 2017, and we're actively tracking those risks and 3 open issues, and we report those to steering and up to governance. I think it might be more appropriate for somebody in the health authority to talk about the management of risks at the clinical level.
Great.
Mr. Guest.
To be honest, I would need a little bit more context from a question to be able to answer it.
I mean, I basically am just looking for the implications or the consequences for a citizen who is involved with the healthcare system and the IT systems that hold their private information break down.
Mr. Guest.
I guess, you know, from a clinical standpoint, when we think about the risks of those situations, our challenge is more how we maintain our operation when we're used to it being in a digital format that may not be available. And we do have processes in place where we do revert back to paper for short periods of time. Examples of that, if this past year we had to make some changes to some technology and we went in a downtime period for an overnight while that happened. And so, you know, that's an example of where we have to put some of those backup processes in place. It's inconvenient. It does create challenges where it takes time to put the information back into the digital environment. And I would say one of the other issues that we run into is, I think when patients come in for service and they tell a provider information, they make an assumption that every provider everywhere can see that. And that's not actually true. If they go to their doctor's office and there's information in their doctor's system, and they go to the emergency department doctor won't necessarily see the information that their family doctor has. And so I think that gives you some context to why some of those issues happen and the significance of them.
Ms. LeBlanc.
I have another question, but just to follow up on that. But with the One Patient, One Record, would that be a change? So my understanding of One Patient, One Record is that, you know, you have a record. And so what I say at my family doctor, then the emergency doctor would have access to that for very good reasons, but will that not change?
Mr. Guest.
Certainly it will make a huge improvement. I think the intent with the One Patient, One Record initiative is that it'll create a foundation that our systems will be able to integrate to so that we can have one true source of information. That's our goal.
Mr. Law.
Thanks. I just want to give you an example of a constituent of mine who is very concerned about the drug information system. They came to my office, you know, they went to get a prescription filled and they discovered that they needed to provide a bunch of information and that this was going into the drug information system. I investigated opt-out options for them, which frankly, for this person weren't adequate. This person happened to have been a victim of the federal student loan information breach and is extremely sensitive to their information being accessed, shared, and is, in my opinion, quite rightly frightened of offering his private information into this system. I'm wondering what you might say to him, or what, you know, how I can offer some comfort to my constituent, given that is the law. There's no way for him to, unless he wants to break the law, for him to not, you know, participate.
Ms. Grimm.
Sorry about that. There are what we call consent directives in Nova Scotia, and patients do have the opportunity to have their information not entered in or to have it masked within a medical record. A lot of our legacy systems, this is a more manual process. The citizen can certainly contact the Health Privacy Office at the Department of Health and Wellness or the health privacy directors within the health authorities and to seek information on that process. I put a cautionary note on that, though, because there is risk associated with not having your information available for direct patient care. And certainly OPOR, one person, one record, is meant to make sure that information is available so patients get the very best care. And so when we talk about consent directives and people who purposefully choose to not have their information in the system and or to have it masked, there is a risk associated with that, and some providers will have difficulty being able to provide appropriate care. But there are processes. Certainly in modern systems, consent directives can be more integrated into the newer modern systems, but we do have a lot of legacy systems, so it's very much a manual process.
Thanks. This question is for the Deputy Minister. I'm wondering if you can talk about when the relationship basically between the Department of Health and Wellness and the Department of Internal Services, when the shared service agreements were being made, or was made, I should say, what kind of relationship did you have with the two, between the two departments? Maybe both of you can answer this. What kind of information was Health and Wellness providing to Internal Services? Were there periods of checking in to see how things were going? Can you talk about that process a little bit?
Ms. Perret.
So I wasn't here during that time, but fortunately we have two people who were, so I'll refer to Jeff and Christine. Yeah.
Ms. Grimm.
Probably appropriate for Internal Services to start because they actually led the Shared Services Initiative, and I'm happy to fill in any blanks after that. But I actively participated and can fill in the department's role.
Mr. Conrad.
You could probably get everybody involved in this. Thanks for the question. So shared services was certainly a long-standing piece of work. So one of the things I would say is that prior to government making the decision to move forward with the shared services model, there were a number of years of work just in general on the shared services model and how that would work. And a number of players here, Janet and I were on committees, Allan and I, Sandra, Christine, many of us were on committees over a couple of year period prior to the creation of the Shared Services Initiative in 2014 that looked at kind of the broad structure of what is shared services, why would you do it, how would it work, what work's going on now in various organizations, where does it best suit, how does it get best placed, what were some of the delivery options. So it wasn't just kind of an instantaneous, let's do shared services and we'll move on. There was lots and lots of excellent pre-work in advance of that. And then Internal Services was created in April of 2014. The Shared Services Initiative was announced shortly thereafter, and we moved forward in a phased initiative. So we originally started in the department with around 550 staff and a sort sort of core set of responsibilities. So the CIO office and a number of other corporate structures, for example, came over in the very early days. A year later, we added the IT units that existed in other parts of government departments. So, for example, Health had its own IT unit that provided services to a number of departments. We brought them and the other 6, I think it was, units over. Then a year later, we added other things, and then in 2016, we brought over folks from the Health Authority. So each one of those transitions, and maybe I'll give Sandra a chance to talk, there was a process by which we go in and figure out which pieces are coming, which pieces are staying, and how do we manage that? Would that be useful in terms of the kinds of communications we had going into these discussions? I think that's what you're trying to get to.
Yeah, if it can be brief. I apologize for saying that, but I know I asked the question and I want the answer, but I also have more questions. Thank you.
Great. So thank you. So there were, as the deputy alluded to, we did a significant amount of work. So when the announcement was made that the health sector in particular was moving over, we took 12 months to plan that activity. Lots of committees, lots of understanding of what are the current services, what are the current systems, the contracts, the number of people, what type of work they were doing, whether a person was doing 100% of the work or 50% or 20%, and then aligning the resources across all of us who would end up supporting the health sector in some way, shape, or form. From a government department perspective, the Department of Health was really the group who had this strategic as well as the digital health responsibilities. So prior to shared services coming together in 2009, the Office of the CIO was formed, and a lot of the technology was pulled in 2009. So the departments didn't have their own email systems or didn't have their own service desks. That was all centralized back in 2009. The second round of shared services really looked at centralizing the applications within each of those departments so that we can have consistency across how certain applications are delivered. So in government, we only have one email system, because believe it or not, prior to 2009, there were multiple separate email systems within government. So the opportunity to standardize and consolidate a number of IT services is really what we have the opportunity to do as part of shared services. So the relationship with the Department of Health was one that we made sure that we continued to provide services, both technical services to them as well as project management services, because mostly their sphere was in the project side of the house as it impacted us. So we made sure that when projects and project managers were transitioned over, they still provided the services to the Department of Health, and we continued to provide other services like geomatic services and things like that to the Department of Health.
Okay, thank you. How much time do we have?
4 minutes.
Okay, I'm going to move on. Thank you. So I just want to quickly go back to what we were talking about before in terms of the implications of privacy or IT systems not behaving as they should. For the record, I think, you know, shared records are a great idea, but I'm really worried given the issues that we've had with the FOIPOP server breach and, you know, it's complicated systems, as you said. So the Auditor General highlighted the potential for unauthorized disclosure of personal health information, increased wait times for services, increased cost of the healthcare system, and overall negative health impacts for people in Nova Scotia. So I'm wondering how exactly could a lack of risk management or lack of clarity around these roles and responsibilities wind up causing this sort of damage? You know, we talk about my constituent, the drug information system is really important, and yet these systems get breached and people's information is lost. So can you talk a little bit about that damage? Thank you. I don't know who this is for.
Ms. Grimm.
I can speak high level to some of the protections that we have in place around privacy. So some of the things the auditor referenced were that could happen. I think it's important to clarify he's not referencing that they did happen. And that was his interpretation of some of the risks associated with that. In order, and I'll look at it more from the DHW perspective, but I expect it's not that different for the Health Authority as well. We do have different approaches to protect information. We obviously have audit. All systems within the healthcare system are subject to a reactive audit. A reactive audit is when we get some kind of advance warning or somebody's reported suspicious behavior. And then we can have our audit teams actually go in and investigate. Some of the newer systems actually have proactive auditing capabilities and more technical capabilities to do that. We often use a system called Fair Warning, which sits on top of some of our systems and allows us, based on the user access matrix, if you're a ward clerk in a particular ward in a hospital, you should have access only to these patients' information. And that proactive auditing, and we do test samples, allows us to actually look at who's had access. If there's anything that's out of the norm or an outlier, then the audit team will actually look and validate should that person have had access or not. And so those reactive and proactive audits do exist within the healthcare system. There's other safeguards we have. We have a lot of administrative safeguards, which is really having contracts, confidentiality policies, operational guidelines. Obviously, training on privacy and security are mandatory in organizations, breach protocols, audit processes, service level agreements, access agreements. And so those are the paperwork that go with this. And part of this is we have to understand people have an obligation. It's not just the IT system here that has to work. We have to have everybody in the healthcare system working together on those pieces. We have some physical protections in place, and certainly Sandra's shop can talk to that. In secure data centers, we house the information, or we have requirements of our vendors who have that information in their systems. And then we also have some very technical pieces on the more advanced systems, stronger user access matrices, firewalls, and we also follow industry best practices. And as the practices around privacy and security change, we actually need to keep up to date on those things as well. From a resourcing perspective, each of our organizations have health privacy offices within them, and people are responsible for managing access to health information and any concerns that come up and doing the due diligence on those. And the other thing, as we enter into projects and programs, we also have various assessments. They're called privacy impact assessments and threat risk assessments. They're done early on in a project, more in a conceptual basis, but as we get closer to implementing the project, they move from being conceptual to being an actual privacy impact assessment or threat risk assessment. And the intention of those are to actually look at the risks, make sure that we understand what is the potential, could this happen, and what are the appropriate mitigations. And so all of our systems do have PIAs and threat risk assessment associated.
Thank you for all of that. So you said you look at the risks. So can you give me an example of an actual on-the-ground example of a risk that could happen to somebody, like where there was an issue with the security or the...
So I don't speak to security.
I mean the system, sorry.
So I think the example that you've already referenced is the drug information system breach that occurred, where there was a pharmacist who, according to her standards of practice, was not supposed to be looking at other people's information that was not within her circle of care. So there's a professional responsibility there as well. But certainly throughout that audit and certainly throughout the review of it done by the privacy review officer, we did look at our processes on how we managed that process, and we've gone about looking at the recommendations that she's put forward, and 8 of the 10 of them have been addressed. So that's an example of when it does happen. We often, and not just unique to Nova Scotia, hear of people who through human behavior have curiosity and want to look at these records. And I will say through a digital system, we have a better opportunity to look at who did that, because these records are they're time stamped. There's audit logs associated with it. We can go back and we can look and we can see where they have had access. So in the case of the drug information system, we know exactly how many people were had their information exposed by this particular individual. And certainly there was a follow-up investigation through the through the College of Pharmacy, and certainly through the organization, the SOBI's organization that the pharmacist worked for, and as part of the report that was published, the pharmacist actually was dismissed.
Thank you.
So there are consequences. So it's process and consequences.
Caucus and Mr. Gleveen.
Thank you very much, Mr. Chair, and pleased to be here today, substituting for a colleague. I do want to get Dr. Jacquard in on the conversation here, and and I guess publicly, welcome to your new position. I know you've been there for a while. When I look at the IWK, of course, you know, you go and visit the Grand Center and the NICU, and some of the research is world class. Where are you in terms of the IT world, and where do you need to go to again be state of the art, if you wish?
Ms. Jangard.
Thanks. Thank you. So I would say that the work that we're doing on One Person, One Record is the first step to take us from a system that, you know, as Ms. Knox said, has organically grown to meet individual needs and individual patients in individual places and individual care provider groups, to something that really is a system that isn't silos. And the reason of sitting here, all of these organizations together, is to understand that the care journey for patients isn't only in one place. And so the first step of that is, how do we unite our hospital systems with an IT system that supports the modern things that we need to do? Not only the information of the patients coming in to care for that particular patient at that time, but to be connected with when they need to go. So in our NICU that you referenced, many of those patients come from elsewhere in the province. They need to go back to their own communities in their province. They need to go to my colleague's care in NSHA. So how do we meet the needs of that family who don't want to have to tell that story over and over again? So the very tight balance, and it is a balance, what is the risk of disclosure of information inappropriately versus what is the risk if we don't have the right information to care for a patient? And I think balancing those risks is more of an issue than thinking of one risk separate from the other kind of risk. So what do we need moving forward? We need to think about being one system. We need to think about one place that we go to get the best information for our patients. And right now that is starting with looking at, when you're in the hospital or using our resources in the hospital, what is that one true one record for that one person, and then looking to have interoperability with what's already out there in our primary care providers' offices, looking at how we actually do know what our best drug history or drug medication history is on someone, because that can be important to know when someone comes in. So if someone comes into one of our emergency rooms and cannot speak for themselves or doesn't have their information from them, how do we get that information out of a system that allows us to take the very best care of them? So that's why this group of people spend so much time working together on those things, because we all have that shared goal of having the best system that supports our clinicians to take care of our patients and families.
Thank you very much.
Mr. Jessel.
Thank you, Mr. Chair. And through you, I'd like to welcome my my colleague, Emily Levine, back to public accounts for the first time in a decade. Thank you. That's actually a great segue to my first comment. I couldn't agree with you more. The reason that we're all here is, you know, we're coming at this today from an IT perspective, but the goal ultimately is improved patient care. It's critical that is, I guess, the focal point of all of our efforts. And I'm really impressed and grateful for the level of positive criticism that's taken place so far today. We've all got a role to play, and it's clear that you know, government, opposition, AG's office, and our respective entities that have joined forces here are all committed to doing this work. I would like to. I mean, we've talked a little bit about, I guess, the response and the activity that's taken place with respect to the AG's recommendations, the AG's office's recommendations, and I'm wondering if we could take a focus on, I guess, the procurement process of for One Patient, One Record. The AG's office was critical that there were some lacking accountability mechanisms and oversight in place, and I'm wondering if one of our witnesses today, or a couple of our witnesses today, would provide some insight about how the procurement process for One Patient, One Record reflects the importance of embedding those accountability mechanisms in place from the start.
Mr. Conrad.
So I'll let Chris Mitchel, the Chief Procurement Officer, speak to this in detail. I'm sure he's excited to get a chance to participate. But I would refer you back to the org chart that Denise has referenced a number of times, just to remind you that in terms of the comments, I think to be fair to what the Office of the Auditor General said is that when you acknowledge and look at the things that were raised in the audit, can we be confident and comfortable that other processes are following a good process and good management practices? And I think, as Denise said, we've spent a lot of time on the strategic side of the house, really thinking about how do we make sure we're doing well these big, incredibly complex pieces of work and projects like OPOR. So I think it's a great example of a place where, although we are certainly taking seriously the recommendation that we learn lessons from the IMIT world, where we already knew there were important things to be done in terms of how we framed up the procurement piece and made sure from the beginning we had really good process and structure around it. So I'll let Mr. Mitchell speak to a little bit of an overview of how we make sure a big procurement like this goes well and is well positioned.
Mr. Mitchell.
Thank you very much. I think it's important, as the Deputy has just mentioned, that one of the things pointed out was we need to learn from things which have happened before. And in fact, right from the very beginning of the One Person, One Record initiative, we were doing exactly that. We brought a number of critical external resources on board right from the beginning, from a fairness monitor brought on to not only later in the process help to determine if we're doing things correctly, but also they helped us from the very beginnings of the design of the process, from the selection of how we would do evaluations, from any number of different critical decisions on the path of that program through the RFSQ or the supplier qualification phase to the now RFP phase. So we've done some things to set some pieces in motion that have created an environment of increased transparency, increased openness, and allowed the government to actually say we've taken it seriously in large, as the mentioned earlier, in these large complex procurements. We went through a very defined conflict of interest and conduct for everybody involved in the program. And so that normally in a procurement process would involve the evaluators or the people who are involved directly in the RFSQ and RFP phase. In this one, we actually broadened that out. We've taken that to everybody who had any kind of interplay in this program at all, signed those conflict of interests, signed the conduct code, because many of the vendors which we were expecting to have to deal with, we do daily business with them on an ongoing basis. So we wanted to ensure that there was a transparency for everybody who was involved from the vendor community, but also some sense of responsibility on the government side. The follow-on from that, though, is, and it's been touched on a couple of different times, there is a very robust governance set up for the One Person, One Record file. It not only is robust in the fact that it has multiple levels and all having their own responsibilities for decisions, but it's across all four of the organizations which you see in front of you today. So there was a recognized need for both departments and both health authorities to be participative in all of the decisions made inside of this, from who would be evaluating, how would we evaluate, what decisions made sense from the very start right to where we are now, which is in an open RFP phase with two very solid candidates who can deliver solutions that we're looking for the Nova Scotians.
Thank you very much. Appreciate that. And my next question was going to be related to, I guess, the governance beyond or the accountability beyond, but I think I'll sidestep that and move forward, because it sounds like there is a heightened consciousness that, you know, the upfront accountability mechanisms have follow-up measures in place once we get to an operational side of things. I am wondering, as we progress, and I mean this is kind of an interesting conversation. I'm not IT savvy by any means, but it's interesting, and it's exciting to see that, you know, as we develop, there's a major amount of opportunity and a major amount of opportunity, I guess, to improve the way that we deliver through the enhancement of technology and the evolution of technology. So it's neat to be a part of this conversation. And in saying that, I would like to ask that, I guess, simultaneous to the work that is going on with respect to improving the governance of these systems, I would like to talk a little bit about the people that were involved from a healthcare provider perspective, kind of generally who or what types of care providers were involved, how many perhaps, and I mean, these are the folks that have to operationalize and maintain the use and adopt the use of these new technologies. So can we receive a little bit of insight as to who was consulted throughout this process?
Mr. Guest.
Thank you for the question. There's been a variety of clinicians from a multitude of disciplines participate in the process all the way along. Certainly, there were clinical individuals that participated in the development of the RFSQ documents. Clinicians participated in the development of the clinical scenarios that were used in the evaluation phase during the current RFP process. And I'll give you a little bit of context into the magnitude of that. We brought together around 331 individuals to do the scenario evaluation. Of those 331, they were from all 4 zones in the Nova Scotia Health Authority. They also were from the IWK. They included 94 registered nurses, 49 physicians. They also included laboratory technologists, dietitians, radiation technologists, physiotherapists, nurse practitioners, pharmacists, infection control practitioners, epidemiologists, and the list goes on and on. It was a fairly robust group of clinicians that came from direct client care roles. They also were researchers, educators, and also administration.
Thank you very much. And through the chair, throughout those conversations, I guess were there lessons learned about how best to onboard healthcare providers to use these evolved systems? And I, at the risk of, to point out something that I think that has been I guess a challenge. When we initiated My Health NS, there's a requirement that physicians and patients actually use the system. So in keeping with that level of consultation with healthcare providers, is there simultaneous work that's taking place to ensure that not only are we creating great systems with accountabilities in place, but is there simultaneous work being done to ensure that our healthcare providers are actually, going to use these things and can use these things in a way that doesn't take away a whole lot from actually providing care to Nova Scotians?
Mr. Guest.
Yeah, I guess I'll give a couple of comments that I could respond to that. Certainly clinicians went with us when we went out and did site visits to see how the source systems were operating in some example locations. They asked really specific questions about how those systems impacted their work lives. They were able to talk to individuals in those organizations who were actually using them. So I think that's one context of which we did that. I think the other that I would say is that we've developed a really robust plan for how we're going to do readiness and develop and how we're going to build the system, and it's very, very clinician focused. There's a multitude of work streams that have been planned with a large number of clinicians that we will populate them with once we move to that phase, and that is the sole focus of that work, is having clinicians participate in a massive amount of work as we standardize what we now would have hundreds of different assessments as we focus going toward much fewer, and they have to be involved. There's no possible way to go forward without them.
Thank you. Through the chair, parallel to the healthcare provider side of the effort, how have patients been engaged, perhaps, and as a like-minded question or a like question, how or what work is being done to ensure that we increase the opportunities for patients to utilize and to maintain one patient, one record when it comes online?
So what we have planned for is adding patient advisors to our work streams. They would be engaged in the process. We've talked about doing focus groups. Certainly both the IWK and the Nova Scotia Health Authority have organization-wide patient and family advisory councils. It would be our intention to capitalize on those as well. I think there's a variety of ways that we can do that, but certainly building that voice in right at the work stream level is an essential way of being able to do that.
Okay, thank you. A lot of my questions initially were around the, I guess, the evolution of shared services, and we have had quite a bit of a dialogue on that thus far. So perhaps I'll pass it to my colleague, Ms. DiCostanzo, for a line of questioning. Please and thank you.
Ms. DiCostanzo.
Thank you, Mr. Chair. I'm actually very excited because finally I hear that we've got our computer system being upgraded and we're moving forward to becoming one. Somebody who has had a couple of constituents calling me, and a gentleman actually from Israel who just moved to Nova Scotia and called, he wanted to tell me that even in little Israel, they can look online and book their family doctor or book an appointment at the hospital, and how come Nova Scotia is not there? So I'm really excited to see that we are moving forward, and I'm sure we will have many different aspects to this new system that I can reply to my constituent and be proud of it. So this is, to me, is a very exciting time. How will we rate? Where are we once we get the process going, and where are we compared to other provinces in Canada or to other systems in the world? What are we aspiring to reach with this one OPOR? And if you can compare us maybe to, I know it's going to take some time to get there, but where are you hoping to reach in comparison to other provinces and other countries? Thank you.
Ms. Grimm.
Happy to answer that question. Certainly Nova Scotia on the journey to one person, one record has done a lot of background information. It started with a business case for change, looking at what did we need to do differently, what problems are we trying to answer in this problem to make healthcare better in Nova Scotia using these systems. Certainly many of the big organizations in the US as well as many across Europe use these big clinical information systems. And so more and more we're seeing published peer-reviewed literature out there on the benefits of these systems. Many of these literature pieces focus on the outcomes associated with a clinical information system, the ability to enhance patient safety, reduce serious medication errors through the alerts and some of the protocols and templates that could be imported into the system, the ability to improve patient care, quality of care, and clinical outcomes, and certainly using that data to be better support patients. Improve patient experience. I think we all have friends, even ourselves, that have gone in and told our story over and over again to a physician or to a resident. And the mere fact that that information is now available for healthcare providers when they come into the system is a measurable outcome of this system that we need to track. Improved access to health information for our health system planners and our clinical program service planners is very important as we go forward as well. And certainly the ability to actually use data to measure improvements in population health. And so the literature is actually showing some of those benefits. They're proud to highlight their work. Certainly in Canada, there are a few similar type of CIS projects underway. Ontario has approached it with some consolidation or working together. I guess it's not consolidation, but...
Please, that ends the time for the Liberal caucus. I'll now move on to the PC caucus. Ms. Adams.
Thank you, Mr. Chair. And I'm going to continue to follow up on the one person, one record. I just want to be clear for when people ask us questions. Once this is in place, will a patient be able to go in and look at whatever is on their record?
Ms. Grimm.
So the system hasn't been procured, so I can't speak to the functionality that would be provided. Certainly access to health information is a priority for the Department of Health and Wellness. It's why we have My Health NS. It's a separate application that could potentially be integrated with the OPOR system, and or these clinical systems also come with patient portals as well. What we've seen again in leading and best practice is it's more than just giving lab results. It's more than just providing specialist reports. There are jurisdictions now that currently enable access to the clinical notes. And so as we go through the remainder of the procurement, we get into negotiations, we identify what we're actually procuring here through that negotiation scope. We'll have a better understanding of what OPOR will do, and we'll also, through our interoperability with some of our core systems, make sure that that connectivity happens to something like My Health NS, so that we continue to evolve that. Right now, our current state is e-results, lab reports, and specialist reports that transition to citizens that are on My Health NS. But there's opportunity to expand that as we go forward with OPOR.
Okay, thank you. And so will My Health NS be over with if we move to one patient, one record?
So My Health NS is the brand that Nova Scotia has chosen to brand the gateway for citizens. And so just like citizens need to know they can call 911 and get an emergency response, or 811 to find out about other healthcare services, My Health NS is a gateway that makes it seamless for patients to enter the IT systems. And so I think we need to focus on the access to the citizens into our systems. They don't need to know what systems are in the back end. They don't need to know what systems a GP in the community is using if they want to provide virtual care. That gateway should enable seamless access for citizens. Again, that's a piece of the planning piece that we have to do. Certainly Canada Health Infoway with their access initiative is focusing on this a lot across Canada, and we're actively involved in those discussions as well. It's a real opportunity. Again, we need that core foundation of the systems, the provider systems, the patient system, the public health to be the core system, and then we can layer on things like e-services.
Okay, and right at the moment with My Health NS, physicians are paid to be using that system, so they have to sign on before a patient can gain access to their lab work or specialist reports. So is that going to change once one patient, one record comes on? Are the physicians no longer going to be paid to be using IT services like that?
So we're actively looking at streamlining the approach for citizens having access to their information. I think I mentioned it a little bit earlier. We appreciate the work that primary healthcare doctors have done to sign up their patients. There is a stipend associated with My Health NS as we speak right now. We also know that there's probably a better way to deliver results directly to citizens, and we hope to do that before One Person, One Record.
Okay, and thank you. And so right now, somebody on My Health NS can email their physician, and the physician has to email them back within a certain period of time. Is that going to change moving forward, or are patients still going to be able to email their physician?
So in My Health NS, the ability to secure email, so I want to make the differentiation, it's not just email, it is secure communication with their provider does exist if the provider is currently on the system. Again, as part of the bigger planning piece that we have underway, there is an opportunity to look at how we provide these e-services. So when we talk about virtual care, there's different ways. Secure communication through an email is one means of virtual care. We also want to look at adding what we call synchronous care, which is device to device kind of care options as well. And certainly work has been underway in the health authorities piloting some options on that as well. So there's planning pieces around this. Most jurisdictions are looking at this. A lot of this work has been done in pilots. Of course, from a provincial perspective, as we look at our planning for OPOR, we want to look at how we do these things once, how we scale them, and not get too caught up in these individual pilot approach.
Okay, thank you. So I'm wondering what happens when I travel to another country or another province to get my medical care. How does that get entered into my record? Or if someone comes from New Brunswick here, they're not having the same one patient, one record system in their province. So I'm wondering what we do about that. And I'm wondering whether there was any discussion that all of the provinces buy into one system instead of each province possibly doing its own thing.
So that has been an ongoing discussion at the pan-Canadian level. I guess it goes to readiness and willingness. I would say we're not there yet. We certainly plan within the jurisdiction of the area that we currently reside. I think the opportunity to make sure that information is available is to give it to the patients, to the citizens themselves. Again, the interoperability of our system with a system in the US, or I give an example, I was in Africa a couple of years ago. It probably is quite a number of years out before we have that type of opportunity. By going into My Health NS, if I have an internet connectivity, I should be able to access my information. Again, we have some limitations with the current strategy right now. If providers have not invited their patients, or if providers haven't adopted the system, and again, I do want to credit them for the good work they have done, but they are busy clinicians. We need to streamline how we get information to the citizen so that the citizen always has that opportunity to provide their medical information if they're able to when they're traveling or in a different province.
Okay, thank you. So you just mentioned that we require internet capabilities, so this province does not have 100% internet capabilities, so hopefully that problem will be solved. What happens if something gets put onto my record that's not correct? What's the steps that I go through to fix that?
So there are processes to be able to make a correction. It needs to be documented in the medical record. So it doesn't get erased from the medical record, it gets documented as an error and a correction. I don't know if one of the clinicians who may have more experience in that want to speak to the specifics.
Ms. Jangard.
So there is a process that is done in paper for how you would make it. So if I write something on a patient's chart that I then find out is incorrect, there is a way in which I need to document that it is an error, timestamp it, and date it. I am not familiar with what the processes are when we go to a fully electronic record. Remembering that in my hospital right now, most of the record currently is on paper first and then is scanned and archived, but those solutions are available. The nice thing about the electronic version of it, it is already dated, stamped, timed, and you know who's made the correction.
Okay, so I'm going to give you a couple of examples. I was in Emerge a while ago and I was given a prescription for a medication. I didn't honestly look at the thing, I just knew what it was for and faxed it to my pharmacist, and they called me back and said, Barbara, your name's not on this. So it never even occurred to me until today. I know that I had to call Emerge and get them to write it with my correct information on it, but somebody else it has their identifying information at the top of it, so presumably it gets scanned into their record. So would Emerge automatically go to correct that on their record, and what would that look like?
Ms. Grimm.
So if I were to understand your question, I think that that would be considered a breach and would have to be managed as a breach.
Okay.
Thank you. That concludes the time for the PC caucus.
Thank
now
you.
I'll go to Ms. Roberts, the NDP.
Thank you, and I'm going to ask everyone who I'm asking questions to respond with brevity, because I know I have far more to ask than I have time for. But continuing for a moment around the one patient, one record, Mr. Mitchell referred to having, two strong proponents, and I know that negotiations are ongoing. There was also some concerning coverage in the media in the fall about the process of going from some 5 interested possible proponents to just 2, and I'm wondering what you can tell me to assure me that I guess that the procurement process has been robust and fair, and also that Nova Scotians are getting the best value for money, given that some possible proponents were eliminated before we got to the final stage of the procurement process.
Mr. Mitchell.
Sure, thanks very much. I think it's probably easiest to answer that in a more wholesome or fulsome sort of way. Very quickly, Fairness Monitor involved very early on in the process, so that's a third party which we hire to ensure that they get an opportunity to provide commentary on decisions like we're going to go with 2 proponents instead of 4 proponents. Why is that? Well, it's because we left that door open when we wrote the RFSQ to say if there was a dramatic difference between the number of proponents, that the government reserves the right to go with the number that they would like to go with. What you have to understand is it's an enormous process. So dealing with what people might say, well, why didn't you take 3 or take 4 of those folks? There was a considerable amount of difference in the technical evaluation done between the top 2 proponents and the third and the 4th proponent. The decision was made at steering that we had the competition that we wanted to make sure for Nova Scotians to ensure we drove the best possible solution, that they were the 2 most technically competent that we saw in the RFSQ submissions. And so I think what we could say is that process was able to take the RFSQ, which had, we expected between 5-6 submissions came in. We took a look at all 5 of the submissions which were forwarded in for evaluation. At that point, 1 was dropped as a result of not submitting all of the information that they were required to. And so we did a full evaluation on the 4 consortiums that were in play at that time. There was a significant scoring difference between numbers 1, 2 and numbers 3, 4. And so the decision was we had all of the competition which we were looking for. We had all of the potential excellent delivery in both of those 2 providers, and so the decision was to go forward with the 2 versus a number larger than that.
And just to clarify, my understanding is that one proponent, that package was never looked at because it was couriered to the wrong address on the day that of the deadline, and even though it was in the same building and it had come from out of country, somehow it wasn't able to get from whatever floor it arrived at to the floor that it was supposed to be on, and therefore it was eliminated. So you feel like we haven't left some value for Nova Scotians sort of, I guess, in the wrong mail slot as a result of that?
Mr. Mitchell.
So the easy answer to that is yes, I'm very confident. The more sort of detailed answer is there's a lot of procurement law which identifies the requirement for bids to be not accepted if they're not at the right place and at the right time or in accordance with the closing times. I know it seems that is a bit of a nuance, but we were looking to protect the sanctity of the entire process, and by letting a bid in which would have been easily argued by the proponents, the other proponents, that it had not been received on time and at the right place, would have called the entire thing into question. And so it's actually a really good example of the transparency and openness that we've followed throughout the entire process, which was tell folks what's required, follow what you tell them, and make sure that you hold steady to what you've actually outlined in your documents.
And when you refer to the use of this fairness monitor, is that body, I don't know if it's a body or if it's an individual, are we as legislators, are members of the public able to see reports from that fairness monitor while the procurement process is ongoing? And how is that, what's the reporting, I guess, schedule?
So it's an actual firm that we went out through an RFP to hire. They have, on our request, provided 2 interim reports to date. One was at the close of the RFSQ portion, and one was at the close of the proof of concept portion, which was in the RFP phase. Those reports have been requested through a FOIPOP process and been released already. And so the answer is there's really no secret in there. What we do is we ask him or the firm to actually sit in on every single decision made, whether it's how we've structured evaluations to whether we followed what we structured them as, to giving us sort of the common person on the street, how would you see this happening, or do you feel that this is fair? They use both a procurement law perspective as well as a legal perspective to give us their feedback on this is what I would do in this case, or this is how I would follow that.
Mr. Conrad.
To Chris's point, while they've been released, if the committee would like us to just provide those to save you the search of trying to find them on our site, we'd be glad to do that.
Thank you, I'd appreciate that. I guess, I mean, part of me is thematically trying to learn from one audit to the next audit, and some of the themes from the recent audit about the breach of privacy are relevant, I think, to the discussion today. Certainly, and one theme for me, or one area to be curious about, is about the relationship and the reliance on vendors. And clearly private sector vendors are very important to the provision of health information and to many different systems that we rely on in government. And yet there is always that need for the government officials, for the public servants, to be working for the public interest, and recognizing that there's a boundary there between the public interest and the private sector interest. Another theme that is coming back to me from the most recent audit report that we examined is the role of Oversight and this Architecture Review Committee. And I'm wondering if anybody sitting in front of me is part of this mysterious Architecture Review Committee that was referenced in the last audit report that we talked about.
Ms. Cascadden.
Yes, so the Architecture Review Board is a committee that exists within information, communications, and IT services. It's a group of individuals. Some of the individuals are representative of the health sector, as well as representatives from other government departments, technical representatives as well. What they do is their role is to look at what we're bringing into our IT systems and to make sure that it'll work within our existing systems, not cause any issues, and is aligned with our standards, policies, processes, and things like that. So they would look at a submission coming in from maybe a project manager, for example, and make sure that the project manager and the project team have articulated what we're buying, what it's going to do, how it's architected, the technical components of the system, what it's connected to, where it's going to reside, and then would make a determination about whether that solution is a good solution and can be implemented, put in our environment, and we support it and manage it, and it doesn't add to the risks associated with having that system in with all of the rest of our systems.
Thank you very much. That concludes the time for the NDP Caucus. We'll now move to the Liberal Caucus. And Mr. McKay.
What do we have, about 9 minutes, Mr. Chair? Okay, thank you. I think we all recognize that the Office of the Auditor General plays a very, very important role in the continuous improvement process in healthcare and many other things, and I think we're all very grateful for the work that is done by the office. I'm going to direct this question to Deputy Denise. The OAG challenged the DHW for not providing leadership, and we've heard some comments on that already, particularly in the sense of these formalized agreements not being in place. And I think that's a message that has carried over into the public domain, a lot of the talk. And I'm just wondering if you could speak to that a little further as to the cooperation between the organizations now.
Ms. Perret.
Thank you. So as you've heard, the 4 organizations work closely together on a day-by-day basis, and we're not that big that we don't know each other and know how to pick up the phone and talk. As I said, there's a basic split in responsibilities between policy and operation service delivery. And in this case, the Department of Health and Wellness plays a policy role. The health authorities and the Department of Internal Services is on that operation service delivery side. In our policy role, certainly the department has been focused on strategic digital technology. So we are talking one person, one record, we're talking the drug information system, we're talking My Health Nova Scotia, and I'm forgetting one, Panorama, in the public health sense. That's been our primary focus, and the structure for those discussions is on the right side of the org chart you see, so there is a governance structure in play. Our senior official, and you've met Ms. Grimm now today, does play on the operational side. She's part of the IMIT steering committee, and that's a busy piece of work. I think where the auditor commented is when there are when that audit found outstanding matters, such as issues that weren't properly documented from their perspective, or a formality around risk assessment, which I want to underscore is important feedback to us, and there's a discipline to that we like. I think the auditor said, well, then who makes sure those things get done at the end of the day, or where does that get reported to? The audit doesn't remove the responsibility for any of those from the responsibility and accountability from each organization, but said, where does it go if it's not happening? And while I think we have it very tight on the strategic side, that's where we combined both sides of our structures. And you can see at the bottom how busy they are. That's where we combined them so they all report up to the Health IMIT Governance Committee. And we have put on top of that an Oversight Committee. The Oversight Committee are the ministers of both Health and Internal Services and the 2 chairs of the Health Authority.
Okay, thank you very much. Switch over to Deputy Jeff. I'm a little confused on one subject, and it's one that the Office of the Auditor General highlights in many of the audit reports, and it's in regard to risk management. And I'm a little unclear still as to where risk management or the different components of risk management are handled between your department, between DHW, and then between the other organizations such as IWK and NSHA. Could you perhaps elaborate on this a bit?
Mr. Conrad.
Thank you, and I think Ms. LeBlanc had some questions in this regard as well during her questions. So I guess one of the things I would highlight is when you read the audit, the work that the office has done to help highlight to us the importance of collaborative and more comprehensive risk frameworks. So to your specific question, I think each of us would undertake our own individual risk processes in terms of the activities that we do. So we recently used our Internal Audit Center, for example, to do a risk assessment of what did we need to do to improve our cybersecurity frameworks and how do we improve those. We know that things have been done around individual project risks. So Christine framed up that we have, from the very first day on the OPOR project, an ongoing risk register that identifies risks, mitigation factors, things we can do to help reduce those risks, because these projects have risks. If we don't do these big complicated projects, there's a risk that healthcare in Nova Scotia will not get better. That's a risk. If we do them, there's a risk that things will happen, like we'll put things on an online system now becomes vulnerable for a breach. That's a risk. What we need to do is to mitigate those risks really, really well. I think one of the lessons in the audit that we need to think about is that when we do our own risks internally to each of our organizations and we don't come together and talk collaboratively about those risks, we miss seeing things. So I think to, a specific kind of concept might be if you think about things like health information, the Personal Health Information Act has a contingency that allows, during a time of an emergency, you can share information on a patient in order to respond to an emergency. The FOIPOP Act doesn't have that. The FOIPOP Act does not allow us to knowingly breach in order to protect patient record. We need to get together and have conversations about what does that mean in practical terms when we're working together on some of these projects? Which risk is higher? Which risk is lower? How do we manage those risks? How do we do those things collaboratively? There may be risks identified in one of our partner organizations that we wouldn't be aware of. IWK works with a certain foundation that they have to share information with. We didn't know that, so on our risk register, we said, oh, all internal clients, very low risk. Someone else says, hold on, we have an external client that uses that system that heightens the risk. So I think the lesson learned for us in terms of the work of the Auditor General is to say in the go forward, we need to do things. So one of the things we're doing is adopting an international framework called COBIT. So COBIT is an IT framework that provides both a strategic framework and an operational management framework on how do you manage IT services. And it doesn't tell you what to do, it tells you what do we think about in terms of how we move forward. What are the critical blocks in managing big collaborative IT systems that you need to work your way through and come up with responses to. And COBIT, which we're just in the process of implementing both on the health side and just starting on the government side, gives us that external framework, independent of what we think, that provides us a framework for things like, how do you share risks? How do you talk to each other? How do you establish risk tolerances and things like that? So a really important message from the Office of the Auditor General, and in part we're adopting COBIT because we know that auditors move to COBIT as the framework by which they audit us. So they look at that standard and say, this is the international standard organization should be held to, and with that in mind, we're in an active process of adopting COBIT, and if you want to know more about COBIT, I'm sure either Christine or Sandra could speak.
Ms. Perret.
I would just add that, and it's part of the action plan that we tabled with this committee. So we have an internal audit function in government, which has a tremendous amount of COBIT expertise, and they are going to oversee a health risk assessment process that we think will take about 4 months to complete, which will, you've heard from both Ms. Grimm and Deputy Conrad that we do risk management on individual projects, and this will be a chance to have a more integrated, coordinated approach to that.
Order, please. Thank you very much. That ends the time for questioning. Now I'll ask the witnesses if they want to make any closing remarks, please. Ms. Perret.
Simply to extend our thanks for having us here today. I think it's a technical subject. It's garnered a lot of headlines in some respects, and so we really do appreciate the opportunity to address your questions and hopefully to have provided some good information to you and to Nova Scotians.
Mr. Conrad.
Thank you very much for having us. Really penetrating, thoughtful questions, and I do appreciate that. Thank you.
Ms. Knox.
Thank you very much for your questions today, and most importantly for your focus on this important tool that will really be a game changer for us in terms of the future of providing services to the people we serve here in this province and beyond. And I just wanted to add, because I didn't have an opportunity to talk, risk management is central to how we do our work. We have enterprise risk management strategies in our organizations. Dr. Jangard can talk to hers. And we together, the other thing I wanted to say is The way we move forward here is around cooperation and a common vision, and I hope that you've seen that this is what we're trying to create here, and that doesn't happen just because we say so. It happens with a lot of hard work and effort, but most importantly, understanding why we're here, who are we serving, and what's our collective and our individual contribution to that outcome. So thank you for your very interesting questions, and stay tuned. This is really important work.
Ms. Jangard.
The beauty of going last is everybody has said everything already. But I'd just like to thank you for taking the time to ask the important questions that hold us accountable for the care that we provide for our patients. We hold that central to what our mandate is, and we want to continue to work on that. So thank you very much, and we're glad that we were here.
Thank you very much for your presentations and your questions and answers. We do have some committee business to take care of, so if you guys want to back up and exit, we can, and we'll just continue on as we go. We do have some correspondence, which is an email from Dr. Krista Jangard, IWK Health Center CEO, clarifying information provided on the February 6, 2019 meeting. And it says that 1, 2, and 7 would be complete by March 31st, 2019. The correction is that it will be 75% complete by March 31st, 2019. And December 31st, 2019 complete. Are there any comments regarding this correspondence? Being none, we'll move it into accepting that correspondence. Ms. Roberts.
I would like to make a motion.
Yes, go ahead.
Whereas the mandate of the Public Accounts Committee is to, 1, examine and inquire into all such matters as may be referred to it by the Assembly, and to report from time to time its observations thereon, with the power to send for persons, papers, and records, and to examine witnesses under oath. 2, review the public accounts of the province of Nova Scotia and the issues raised in the annual report of the Auditor General, which have been referred to the committee. And 3, examine and inquire into any other financial matters involving public funds of the province of Nova Scotia. And whereas changes to the way this committee operates made over the course of the past year have weakened the committee's ability to exercise its mandate, and whereas changes made to the schedule of tabling of audits by the Auditor General in spring 2018, along with the reduction of in-camera meetings, has allowed more room in the committee's schedule to examine departmental implementation of Auditor General recommendations. Therefore, be it resolved that the motion of Mr. Gordon Wilson of the 6th of February 2019 be rescinded.
Comments? Ms. Lawrence-Croft.
May we have that in writing in a recess, please?
Sure. We shall recess, but we'll have to ask the committee. We may have to extend the time. If we're going to recess, we're going to extend the time by that far. Is everybody okay with that? Okay. We'll recess for a few minutes. We'll give you... Ms. We'll take a short recess. We'll come back at 10:55. Good. Order, please. We'll call the meeting of the Public Accounts Committee back to session. So the motion at hand is that the Public Accounts Committee rescind the motion of Mr. Gordon Wilson of the 6th of February 2019, which limited the committee meetings to monthly. Any further question? All those in favor of the motion? You can, Ms. Roberts.
I'm bringing this forward because I think it's very important that this committee do a reset and recognize that for this committee to function as it is intended to function, it requires a certain amount of cooperation across parties. And the motion that was brought forward at our last meeting layered on top of the motion last September has contributed to a situation where I fear for the future impact and efficacy of this committee. I also asked the clerk to circulate a sort of I call it a cheat sheet, but it's actually called a quick reference to the role of Public Accounts Committee members. And of particular relevance for me is under the Vice Chair's role. The Vice Chair, of course, is ordinarily Mr. Gordon Wilson. He's not here today, is usually a member of the governing party, assumes responsibility of chair in her absence, works with the government to build support for the committee and sets a cooperative tone for the committee. There's been lots of justification for changes that have been forced on the committee unilaterally by the Liberal members using their majority on the committee, justified by what is best practice or what every other committee does. Well, the fact is that across jurisdictions, one of the most important practices of the committee is that work is done to make changes in a way that keeps everybody feeling like they are on the same committee and on the same side on behalf of taxpayers, working together to hold the operations of government to account for how taxpayers' dollars are spent. This is about good administration. It's about good government. And my particular objection to the motion of last week was that it was entirely unilateral and it did not set a cooperative tone for this committee going forward. In addition to the fact that saying that this committee can only meet monthly means effectively we will not have time. Now, a full year before Mr. Gordon Wilson raised these great concerns about the committee functioning because of the Auditor General writing a report sort of, asking us to make sure that we were scheduling departments about their implementation of recommendations. The Auditor General said essentially the same thing here in committee, after which, over a period of months, I made the proposal that, well, why don't we create some more space in our schedule to schedule departments, and we can do that by eliminating in-camera meetings. We used to, as this committee, meet for a full committee meeting in camera after performance audits were tabled, and therefore we can, instead of having 2 meetings with the Auditor General per performance audit, we could just have 1, and that will create more time to actually schedule in the departments. That change was made last April with the hope that there would be more room in our committee to hear from departments so that we could fulfill that important component of our mandate, which is to hold departments to account. I am fully in favor of that, fully supportive and wishing for us to work well with the Auditor General's office. But the fact is that this committee will not work well if it is the Liberal majority making changes without setting a cooperative tone for the committee going forward. So that is the motivation behind this motion.
Ms. Adams.
Thank you, Mr. Chair. I would just like to speak in favour of this motion on the same document that was provided, the Canadian Audit and Accountability Foundation On the common questions to consider when evaluating the PAC's effectiveness, it said, what percentage of the chapters of its audit reports and other mandated reports does the committee plan to examine annually? So it goes to the heart of the issue as to how much can you get done if you're going to meet monthly versus weekly. The only people who are being hurt by going from weekly to monthly are the Nova Scotians that we represent. There is no logical reason for silencing the PAC 3 of the 4 weeks of the month. And so I believe that Nova Scotians' best interests are served by returning back to the weekly meetings for the PAC. And I'm going to be supporting the motion.
Mr. Jessam.
Thank you, Mr. Chair. And I'd just like to add that, you know, if we're talking about the spirit of cooperation, I think today's meeting was a prime example that that ability, that function of this committee still exists. We're all 3 parties able to ask direct and critical questions of our witnesses today. Our position has been made clear. This is the direction that we believe is it doesn't take away from our ability to be critical of government entities, and our caucus will not be supporting this motion. Thank you.
Ms. LeBlanc.
Thank you, Mr. Chair. I would agree with Mr. Jessam in that today's meeting was a prime example of how effective this committee can be, and cooperation is key, and I think that that's exactly why we need to support this motion. The fact is that we can be extremely effective when we have witnesses in front of us, and therefore, because we have so much to talk about and so many reports to go through and so many witnesses to call, we need to be meeting more often. The fact is that 12 meetings a year will not address all of the Auditor General reports and the witnesses we need to call in relation to those reports. This is an extremely important committee to hold government to account, but not only that, just to hear from witnesses and to hear and to clarify what's happening in departments. Nova Scotians deserve this information, and they deserve to get the full picture of what's happening in the accounts of the province and in the performance of departments in the province. And so I too feel we need to again, I want to reiterate that I agree with Mr. Jessam in the spirit of cooperation. It's such an effective committee that we should be extending that effectiveness to meeting more often weekly if we need to. Thank you.
Ms. Adams.
Thank you, Mr. Chair, and I just want to comment on what Mr. Jessam said about the fact that going from weekly PAC meetings down to monthly, and I quote, doesn't take away from our ability to get answers. Well, it may not take away from the government's ability to get answers, but it certainly takes away from the opposition parties to get answers, and from Nova Scotians who watch this intently to find out how our money's being spent. So I will disagree that it doesn't take away from our ability to get answers. It's exactly what it does. It takes away our ability, and it knocks it down to 25% of what we had the ability to do before this motion was passed.
Any further discussion? If there's no further discussion, we'll have a recorded vote. So on the motion that the committee rescind a motion, Mr. Gord Wilson of February 6, 2019, which limited the committee to monthly meetings. All those in favour will have a recorded vote, starting with Mr. McKay.
Nay.
Mr. Glavine.
No.
Mr. Jessam.
No.
Ms. Lonis-Croft.
No.
Ms. D. Costanzo.
No.
Ms. Adams.
Yes.
Ms. LeBlanc. Or Ms. Roberts, sorry, wrong order.
Yes.
Ms. Roberts. Or Ms. LeBlanc, sorry.
Yes.
And I would say yes. Motion's denied. Further business, Ms. Adams.
Thank you, Mr. Speaker. I have a motion to put forth, and there are copies for everyone here. Whereas on Thursday, February 14, 2019, the Minister of Transportation and Infrastructure Renewal in a media scrum repeatedly denied knowing the details of an agreement to move the port of call for the Nova Scotia to Maine ferry. Whereas subsequent media reports indicate that the department had been in possession of information dated January 23, 2019 that outlined the details of the move, that the cost could be as much as $5 million, and that the province was expected to be a funding partner. Whereas, to my mind, there are 3 possible outcomes. Number 1, the minister knew the details and the cost and knowingly represented otherwise. Number 2, the department had entered into a financial arrangement without the knowledge and approval of the minister. Or number 3, the minister approved the spending without fully understanding the details that he approved. Whereas the function of this committee is to review the public accounts, the annual report or other reports of the Auditor General and any other financial matter respecting the public funds of the province. Whereas there are serious questions about the funding for this service and whether the upgrades in Maine were properly approved. And whereas the sailing season is mere months away and there is tremendous amount of uncertainty, this issue demands the scrutiny of this committee immediately. Therefore, be it resolved that the Public Accounts Committee approve and immediately schedule a meeting on the topic of funding for the Nova Scotia to Maine Ferry, including the funding for land or leasehold improvements and any staffing or services in Maine. Witnesses to include the Minister of Transportation and Infrastructure Renewal and the Deputy Minister of Transportation and Infrastructure.
Comments, Ms. D. Costanzo.
I would like to call a 5-minute recess, please, so we can discuss this. Thank you.
Adjourn. 5 minutes adjourn. Order, please. We'll call the meeting back to order. On the motion that the Public Accounts Committee approve and immediately schedule a meeting on the topic of funding for the Nova Scotia to Maine Ferry, including the funding for land and leasehold improvements and any staffing or services in Maine, witnesses to include the Minister of Transportation, Infrastructure and Rural and the Deputy Minister of Transportation Infrastructure. Any question on the motion? Ms. Lawrence-Croft.
Thank you, Mr. Chair. This is an important topic for Nova Scotians, and it's very important for my constituency in particular. We rely on the ferry for a lot of economic development, and therefore I'd like to amend the motion that this be taken to the Resources and Economic Development Committee, which I am the chair of, and be put on the agenda at next week's meeting.
I'm just told by Legislative Council you can refer it to the Resources Committee, but you can't put it on the Resources Committee. Ms. Lawrence-Croft.
I will, we refer it to the Economic Development Committee and have the Deputy Minister, not the Minister, in.
So that's not a motion for this committee?
No.
Okay. On the topic of the motion at hand, any more comments? Ms. Roberts.
I am also sit on the Natural Resources and Economic Development Committee. My experience at other committees is that they do not have the same way of operating. There is not the same focus on administration of government. The Public Accounts Committee is a different committee than other committees in a number of ways, including the fact that opposition members get a more substantial amount of time for questions, but also the focus on the administration of government as opposed to policy. And so I want to register that in no way is referring a topic from public accounts to another committee. It's not a substitution of the same thing. That's the point that I would like to make. And I think if we have a concern about the administration of public resources, then that belongs at this committee.
Ms. LeBlanc.
Yeah, I'd like to echo what my colleague has said, and it is an important discussion. We should be talking about it in public accounts in the way that public accounts is mandated to work, with televised, with, as my colleague has said, the way the time is allotted for questioning, etc. To me, this speaks exactly to the reason why we need to have more public accounts meetings. We should be mandated to have meetings weekly so that we can we are able to adjust for these types of circumstances. And so while I appreciate the Liberals' effort to collaborate, I don't believe that this does the trick. So I wouldn't be able to support that motion, I don't think.
Ms. Adams.
Thank you. So I don't support the amendment to the motion. If my colleague is as interested as I am in hearing Minister Hines and the TIR department, she'll understand if I don't want to pass this along to another committee that may or may not bring it forward. There's no guarantee that it would be brought forward. So I'm not in favor of the amendment to that motion.
Ms. Roberts.
Sorry, no.
Oh, sorry. Any further comments? On the amendment to the motion to refer to Human Resources, all those in favor of the motion? Recorded vote has been asked on the amendment. We'll now record the vote beginning with Mr. McKay.
Aye.
Mr. Glavine.
Yes.
Mr. Jessup.
Yes.
Ms. Lawrence-Croft.
Yes.
Ms. DiCostanzo.
Yes.
Ms. Adams.
No.
Ms. Roberts.
No.
Ms. LeBlanc.
No.
And myself, I would say no. Motion is carried. On the main motion that the Public Accounts Committee approve to schedule that meeting. All those in favor of that motion signify by saying aye.
Sorry, can we clarify that?
The main motion was that the Public Accounts Committee approve and immediately schedule a meeting on the topic of funding for the Nova Scotia to Main Ferry, including the funding.
It's been amended now, right?
It's amended, so it's now a reference to the Resources Committee.
Okay, so the main motion is down to the Resources Committee.
So we don't need to revote?
No. All those in favor of that motion? All those contrary-minded? So the main motion now is amended that it be sent to the Resources Committee. All those in favor of that motion to send it to the Resources Committee, signify by saying aye. Contrary-minded? Motion is denied. Or carried, sorry. It's carried, sorry. Is there any further business to come forward at today's meeting? If I may, I got to say that the spirit of collaboration that we've supposedly wanted to work with here has gone out the window. And I got to say, I'm very disappointed in the committee that we bent over backwards since I've been the chair to be collaborative in this committee, and we've brought it to the attention that we would do public accounts from the Auditor General's report, but the mandate says others, and I'm very disappointed in the committee members, especially on the side that keeps denying anything else that would come to this committee. So I just had to get that on the record. The meeting is adjourned.